I would be talking about FCPD, and I would start with a bit about the historical perspective and clinical peculiarities to understand how and why we reached up to the gut and the glucagon and why they might be useful in FCPD. So, a routine patient not as exotic as the one that was presented. This is a 26-year-old male coming with difficulty in night vision for 1 year. As you can see, there are clear bited spots which are visible, and the pancreatic calcification is quite clearly seen on the ultrasound and the CT scan, suggestive of a diagnosis of FCPD with a severe vitamin A deficiency, WHO grade X2. So if we look back at the history, of course, Vellore has had a role in identification of this disease way back in the 1950s, followed up with seminal work done by Professor G. Verghese, who first reported the still now largest series of more than 1,700 cases of FCPD. Roughly, these would be the criteria based on which we diagnose it. People coming from a tropical country, exocrine insufficiency, diabetes occurring fairly early, and by and large requiring insulin with widespread pancreatic destruction on a CT or an ultrasound. Now this is from the WHO 1985 meeting, where very interestingly malnutrition modulated diabetes was initially classified into FCPD and protein deficient diabetes. Over time, the MRDM has gone out of use, but FCPD still remains. However, recent studies suggest a drop in the percentages of this disease, with around 3.5 to 3.8% being quoted with recent studies. Also, looking at the clinical profile very briefly, we find a progressively increasing age of onset of the disease. Microvascular complications still remain the major cause of morbidity and subsequent mortality, mostly due to nephropathy and pancreatic cancer. Studies from Vellore have also looked at cardiac autonomic neuropathy up to the tune of 40 to 60% in these patients. A very unique spectrum differentiating it from alcoholic pancreatitis would be the large ductal dilatations, the marked degree of fibrosis, and a very rapid onset to pancreatic cancer, as was seen in the case which has been presented. Of course, studies done by a group of Dr. Mohan has also looked at the pancreatic calculi, and what they found are these are mainly rich in calcium carbonate, and there's a multi-layered and multi-stage deposition of the calculi. So these are work done in the 1990s, which very beautifully bring out the pathogenesis of these stones which form in the pancreatic duct. So the initial concept, as many of you are aware, was the one proposed by G. Verghese, where it was thought to be the tuberous food like cassava. However, studies done in bonnet monkeys and subsequently by the group of Balakrishnan has disproved this hypothesis. The current thinking centers around a combination of micronutrient deficiencies, familial aggregation, and genetic factors, predominantly there is PINK1 mutation, and this has led to the till now proposed hypothesis of a two-hit phenomena where the genetics leads on to the alternative pathways contributed by the environment, maybe infection, maybe something which we don't know yet. A very recent paper from West Bengal actually suggests that isolatedly looking at the SPINK1 mutation may not be enough, and we may need to look at more mutations in this group of people. Coming to the metabolic alterations, now of course, as you can make out from the extensive pancreatic atrophy, it's not a surprise that insulin secretion defects are widely reported and that they are well established. Again, ketosis resistance has been thought to be a major feature of this disease. Multiple hypotheses, not all of them are proven, of which residual beta cell function, loss of glucagon reserve, resistance to hepatic ketogenesis, and a reduced supply of non-esterified fatty acids are thought to be behind this phenomena. However, when we looked at, I started working with FCPD during the time of my DM thesis, and we started looking at things like insulin resistance, glucagon, and finally arriving at the gut incretin axis because there's sparse literature on these. The initial Indian studies were mainly based on HOMA-IR in insulin resistance, studies from West Bengal again and also from southern parts of India, and they do suggest a degree of insulin resistance, but we're lacking the dynamic state-of-the-art techniques which we subsequently used. So when we were planning for the lean diabetes study in collaboration with Professor Meredith Hawkins at Albert Einstein, we planned to look at the same set of dynamic tests, including euglycemic clamps, mixed meals, and NMR spectroscopy, to mainly look at the glucose and metabolic fluxes in this group of FCPD. Of course, I must mention the role of two people, Dr. Padmanabhan and Dr. Shajit, whose hard work were instrumental in getting these very extremely difficult clamps. As you can see, probably you'll be looking at this picture multiple times over during this conference in different presentations. This is the stepped 6-hour euglycemic pancreatic clamps, which were done for the first time ever in these FCPD patients. Now, when we looked at the results, obviously there was a degree of hepatic and peripheral resistance in these people along with insulin secretion defect. But what was very striking and unexpected was the finding of both basal and postprandial hyperglucagon secretion in these people, which was way above the normals and even the type 1 controls. Subsequently, we decided to take a step back and plot the natural history of the disease. So we looked at tropical chronic pancreatitis. This is the form of disease where diabetes has not yet developed. We collaborated with Dr. Sudipta from the gastro department, and we managed to get these subjects and again have these same kind of tests, including the clamps and the mixed meals in them. And what we did is we divided them according to the natural history of progression of the disease. So we had a subset of TCP with normal glucose tolerance going into impaired glucose, then FCPD, and then the advanced stages. Now, some very interesting data which came out was the striking hyperinsulinemia and increased insulin secretion, which seems to dominate the picture in the initial stages, in the TCP stages. With subsequent progression of the disease, there seems to be a loss of the beta cell reserve, something very similar to a type 2 picture, which is unusual for what has been till now described as a secondary diabetes. This was paralleled also by an increase in hepatic fat in the TCP patients, an increase in triglycerides, and also an increase in hepatic glucose output, which also over time did come down, though the FCPDs still remained hepatic resistant. Even for peripheral glucose uptake, as you can see, there is a significant deterioration of the glucose uptake, leading to resistance as the disease progresses. The other important thing, as you can see clearly here, the NGT and more so the IGT. So as the disease progresses, and even before diabetes has set in, there seems to be a significant amount of increased glucagon secretion, suggesting that everything may not be down to the secondary effects of the exocrine defect, or everything may not be coming from the beta cell as thought till now. Again, Dr. Praveen was a diabetes fellow, and this was mainly his dissertation work that led to this bit of studies on the tropical chronic pancreatitis. Now, of course, the question is, can insulin resistance be explained in these patients? When we reviewed the literature, of course, this is from type 3C or chronic pancreatitis, not so much from FCPD per se, but there are two suggested mechanisms. One is the role of pancreatic polypeptide in reducing the glucose uptake and increasing postprandial hyperglycemia. The other is a defect with the internalization of the GLUT2, which actually controls the hepatic level insulin sensitivity. And we feel that both of these may be at fault in these patients with fibrocalcific pancreatic diabetes. So during this part of the study, as endocrinologists or diabetologists, we probably get to see the tip of the iceberg, which is the FCPD. But what our studies suggest that the disease may have started much more earlier at a subclinical level, where you can see significant amount of metabolic alterations, something which starts out very similar to a type 2 diabetes-like picture in the TCP, which again makes us think whether anything other than the exocrine insufficiency is actually driving these patients to develop diabetes, and subsequently as the disease progresses, they land up with beta cell failure and insulin secretion. What stands out in our set of studies is the significant amount of glucagon secretion which has persisted across all the subgroups. We also wanted to look at clinical correlates from other studies that were done at us at CMC as well as other centers to see whether this is matching with clinical findings of supposedly high glucagon. Now this is done by Dr. Kishore way back in 2013-14. Obviously we don't have glucagon values at that time, But what was striking, even when we repeated energy expenditure in our subsequent population, was that BMI-adjusted resting energy expenditure, despite their very low BMI, was significantly greater than even the type 2 diabetes patients. And molecules like glucagon, as you know, have a significant effect on accelerating the energy expenditure. Again, this is a study which I was associated with when I was working in West Bengal, and this looked at diabetic ketoacidosis in patients with type 3C, of which we had a significant number of patients with FCPD. We detected around 11% of FCPDs have ketosis, and then we compared those with ketosis as opposed to those without, and even type 1s. And there again, we found glucagon to be significantly different between the groups. Subsequently, we planned a study around looking at hypoglycemia, because that is the other clinical impact of a glucagon that can be there. And we found that with increased hypoglycemia unawareness, and we divided them into people who were unaware as opposed to those who were aware. And we also looked at glucagon levels in these people. And to our surprise, we found that there was a dichotomous pattern of glucagon secretion, and people with improved hypoglycemia unawareness were the ones who had the highest levels of glucagon secretion. So studies done over nearly 6 to 7 years clearly pointed that there was a problem, there was something happening with the glucagon. What really was the missing link for us, was the challenge for us, was with that gross level of pancreatic destruction and atrophy. Where was this increased source of glucagon coming from? Something which contributes to both post-absorptive as well as postprandial glucagonemia. Was it from the pancreas, or was it an extra pancreatic source? If so, was it from the gut? And is there a role of the gut hormones in influencing the diabetes in FCPD? So these were our challenges that we had in front of us. Referencing the literature, we had the study done by Philip Knopp published in Diabetologia. This was done in patients who had complete removal of their pancreas. And in them, they have very clearly shown, doing paired OGTT and isoglycemic studies, that the L cells of the gut are capable of producing glucagon along with GLP. So we wanted to reproduce the same set of investigations in our cohort of FCPD patients. Just to give you a brief overview about physiological basis for this. Now, the common glucagon that we all know coming from the alpha cells is mainly mediated by the prohormone convertase 2, and that results in increase in glucagon and a lot of intermediate fragments. Whereas the gut glucagon, when it is increased, along with the glucagon, there should be an increase in GLP-1 and oxyntomodulin. So if we are able to prove a simultaneous elevation in glucagon, GLP-1 and oxyntomodulin with a suppression of C-peptides, then it suggests that probably the source is the gut and not the pancreas. So that was our working hypothesis when we embarked on this study. So as I said, this was a very elaborate study. Patients were admitted, they underwent an oral glucose tolerance test, the OGTT. This was followed by an IIGI, which mainly involves challenging the patient with the same load of glucose through an intravenous route. And very similar to a clamp, the challenge was to kind of replicate the exact glucose pattern that the patient had during the OGTT. That had to be replicated during the intravenous glucose challenge also. This was done by measuring the glucose every 5 minutes with a glucose analyzer and modifying the dose of glucose that was administered. And as you can see, after a few trials, obviously this is not our first patient, we failed quite badly in the first few cases, but after a period of a few weeks, we managed to achieve quite a good amount of accuracy. And you can see the OGTTs and the IIGI, as they are known, almost paralleling each other on day 1 and day 2, suggesting that exact load is being given on the 2 different days. And here you can see the same glucose level excursions in the controls as well as in the FCPDs. So what were the hormonal responses to OGTT and paired IIGI? I'm sorry, the graphs may not be that visible because I had to fit it on the slide, but in a nutshell, there was an increase in the glucagon, the GLP-1 and the oxyntomodulin. C-peptide and pancreatic polypeptide were suppressed, suggesting that definitely the pancreas was not at work. And another interesting finding was the blunted response of GIP, something which we were not expecting at that point of time. Again, further data from the glucagon, as you can see in these people, there is significantly higher levels after OGTT. And this rise in glucagon, if you see this graph, it shows very beautifully the glucagon almost paralleling the GLP-1, suggesting that possibly they are coming as if they are coming from the same source with the same amount of glucose challenge being given. And we also looked at correlations with postprandial rise in blood glucose, and the OGTT glucagon again seemed to have a good correlation with postprandial hyperglycemia, pointing to possible pathological or pathogenetic role of this glucagon. So one of the questions that struck us was why GIP was low, because that was not something which has been commonly reported in literature. So we looked at the literature and we found this study done in cystic fibrosis, though the nature of diabetes is quite different from that seen in FCPD. But one of the hypotheses was that now all of these patients are on pancreatic enzyme supplementation. But despite that, when you supplement someone with a malabsorption or a disease like FCPD, they may not completely normalize the gastric emptying. Now the L cells are in the distal small intestine and they are stimulated properly related to the GLP response. However, the K cells being more in the proximal small gut may take time to recover, and hence the stimulation may not be appropriate. There may also be faults with gastric emptying and gut motility in these patients. That's again another area which has been largely ignored and something which we can look at in the near future. Also, I must mention this paper from West Bengal by Professor Sujoy Ghosh and colleagues, which again looks at incretins in FCPD, and very similar to what we have found, though the GLP was increased by almost 1.5 to 2 times, the GIP response was blunted, suggesting that this could be an ubiquitous phenomena in people with FCPD. So coming back to our original hypothesis, as is obvious from the levels of the C-peptide and the pancreatic polypeptide, that the pancreas is possibly the age-old thinking of the alpha cells being at fault for the high glucagon, reduced insulin secretion leading to the high glucagon coming from the alpha cells may not be tenable in this case. Rather, the simultaneous and almost parallel increase in the glucagon, GLPs and oxyntomodulin suggests that the L cells of the gut may be something which we need to look at in these patients. Dr. Shivendra, one of our DM registrars, again was the person who had this as a dissertation, so much of the hard work in these very extensive and elaborate studies have been done by him. So to summarize the findings that I have discussed over a decade of work with FCPD, this has been the traditional view that has been held all along, a very simple model of beta cell and alpha cell destruction, global loss of insulin and glucagon, combined with fat malabsorption, leading to a predominantly insulin-dependent, ketosis-resistant form of diabetes with significant steatorrhea. We propose that it could be time to think of the gut as a major player. Definitely from our incretin-based studies, it is clear that the glucagon, insulin, and pancreatic polypeptide sources of the pancreas with the extensive destruction on display is not at fault. There may or may not be a pancreatic factor that is driving all of this. We are yet to find that. However, the L cells with a selective upregulation of the prohormone convertase 1/3 may be the one driving the secretion of the GLP, the glucagon, and the oxyntomodulin. This in turn can affect postprandial as well as fasting hyperglycemia, and can also explain the findings of the insulin resistance that we have been finding in our cohort over the last few years. Glucagon has a negative feedback inhibition on the K cells, as also altered gastric emptying may be at fault. This could possibly explain the GIP response, with selective prohormone convertase upregulation being the key mediator. As with all research, this has left us with more questions than answers. Looking at intestinal biopsies and immunostaining, gastric emptying studies, and stable isotope studies are something which we are looking forward to. I would take a couple of minutes to thank all the people who have been behind this volume of work. Obviously, our thanks to the Albert Einstein Institute and Dr. Meredith's team, Professor Nihal, and of course, the fantastic metabolic research team that we have in place, the diabetes nurse educators, consultants, colleagues, and my juniors in the department who have helped us over the years. Thank you so much.
It's very difficult to follow up after a beautiful talk like what we heard from Riddhi. So I'm going to go to a little bit more base level talk, talking on exocrine insufficiency. And we move our attention from beta cells and delta cells to a more important cell within the pancreas, the acinar cells. And as you would all know, the acinar cells have the greatest rate of protein synthesis of any mammalian organ. And if you look at the endoplasmic reticulum and the Golgi apparatus within the acinar cells, the huge number of them, just reflecting the amount of protein and enzymes that is being produced by the acinar cells themselves. So the acinar cells tend to produce a bunch of enzymes, including some of them are in the form of proenzymes, some of them are in the form of enzymes. The primary objective, of course, is in the digestion of both carbs, fat, and protein. So therefore, we have amylases, lipases, and proteases. And therefore, there are a host of other proteases which are mostly formed in the form of proenzymes that are secreted by the acinar cells. Now, if you look at the way of how pancreatic secretion happens, there are three phases. And just going back to basic physiology, we have the cephalic phase, which is predominantly mediated by the vagus, which constitutes 20 to 25%. Second, of course, is the gastric digestion, which is a minor component of pancreatic enzyme secretion. And the last, of course, is the intestinal phase, which is predominantly mediated by cholecystokinin and secretin and constitutes about 50 to 80% of the surge in the pancreatic juices. Primarily, when the chyme enters the duodenum, that's when it's triggered off. Now, there have been extensive studies, and this is a paper way back in 1970s, which showed that as the pancreatic secretion decreases, as there's deficiency of enzymes, the patients tend to manifest both steatorrhea as well as creatorrhea, that is protein maldigestion. And this is directly correlated with the production of both trypsin and lipase. Taking it further, so pancreatic endocrine insufficiency primarily occurs because of four major reasons. Whether there is a reduction in the acinar cell mass, there's an obstruction to the flow, as the acidic duodenal pH, and insufficient stimulation for pancreatic enzymes. Now, if you look at it, there's one particular disease which affects all these areas, and this is chronic pancreatitis, as Riddhi would call it, fibrocalcific pancreatic diabetes. For gastroenterologists, we call them chronic pancreatitis, and chronic pancreatitis affects both the reduction in the acinar cell mass, there's obstruction to the flow because of formation of strictures, and because of obstruction to the flow, there's not only a defect in the acinar cells, but also the ductular cells. As a result, there's a decreased production of bicarbonates, leading to an acidic duodenal pH, which leads to inactivation of whatever little enzymes that is being produced by the pancreas. So if you look at it, the most frequent cause of pancreatic exocrine insufficiency has been chronic pancreatitis, but this is usually delayed by about 10 to 15 years since the symptom onset. And this is multifactorial, as we discussed earlier, that is with the loss of acinar cell mass, decreased bicarbonate production, and decreased micelle formation. Now, how do we evaluate pancreatic exocrine insufficiency? Now, if you look at, there are two types of tests that we talk about, both direct and indirect. The direct tests have been primarily aimed at stimulating the secretion of both enzymes as well as bicarbonate. So we have the CCK stimulated PFT test, which has a very high sensitivity and specificity, measures pancreatic enzyme output directly. The problem being it's invasive, tubes that are required are not available, and you can see it's extremely expensive. Secretin stimulated PFT again has a good sensitivity and a very high specificity, and had a very high negative predictive value to diagnose early chronic pancreatitis. Again, the tests are invasive. There's a false positive, especially in patients who have CFTR mutations, patients who are smoker, and it does not test the acinar function. It only tests ductular function. Limitation, again, in a resource-limited country like India and South Asia is, of course, cost. So we come back to two other tests which we were using. This is one test we were doing in this center at least a couple of years back. This is coefficient of fat absorption, or the 72-hour stool fat as it was popularly known those days. It has a very high sensitivity, moderate specificity, high accuracy of fat absorption, can monitor treatment, non-invasive. The problem with this test is that the patient is required to take fat for 5 days, a high volume, almost about 100 grams of fat for 5 days. For the first 2 days is a loading day, and the last 3 days is when the patient has to collect all the stool that is produced. So it's extremely unpleasant, not only for the patient, but also for the technicians who are involved in the process. As a result, this went out of favor, and therefore, now the most popular test that we use is something called the fecal elastase 1. It's a very high, it's a relatively okay test in terms of sensitivity and specificity is concerned. It's a convenient test, but it's a very low accuracy in diagnosing mild exocrine insufficiency, cannot be used for monitoring treatment. More importantly, in patients who have diarrheal stools, you can get false positive results. The advantage, of course, it's very easy to do and the cost is effective. So what exactly is elastase 1? Elastase 1 is a serine endopeptidase produced by the pancreas. Now this enzyme is stable at a wide range of pH and resistance to proteolysis. More importantly, you don't need a huge amount of stool. Only a very small amount of fecal matter, a spoonful, is enough to do this test. It's stable across temperatures of room temperature for 3 days. So the advantage is the patient can mail it to the the laboratory. The only important thing is that if there is diarrheal stools, you can get false positive, and so therefore one needs to freeze dry the sample to prevent low results. So we did the study a long way back just to assess how fecal elastase 1 compares to what was the 72-hour stool fat. And it had a very poor comparison with the 72-hour stool fat. Basically, both of them look at two different enzyme systems, so probably this was not good to look at the comparison. Overall, if you look at the sensitivity, then there are two cutoffs that we available right now. We have a cutoff of less than 200 and less than 100. If you use a cutoff of less than 100, the sensitivity is 84%, the specificity is 47%, and it's got a good positive predictive value. So for our center, we tend to call exocrine insufficiency only when the fecal elastase 1 is less than 100. But again, as we just discussed, that the comparison, when you compare it to the 72-hour stool fat, it does not do very well. So the question that begins is, in patients with fibrocalcific pancreatic diabetes who have advanced calcification, is there a value in doing fecal elastase 1? So what we saw in this study was that in patients who have calcification, parenchymal thickness, or a ductal diameter of more than 8, or intraductal calculus, most of them do tend to have fecal elastase 1. So therefore, when you have advanced images showing advanced damage, there is no point in wasting money and doing a fecal elastase 1 test. So you might as well start them on enzyme replacement therapy. So now world over, most of the guidelines actually now recommend the use of fecal elastase 1, including the UEG, the UK Consensus, and the American Gastroenterology Society. So the question is, when do we test it? So in patients who are asymptomatic and you want to look at early evidence of pancreatic exocrine insufficiency, fecal elastase 1 does not fare that well. So therefore, in patients who are asymptomatic and you are looking for malabsorption, maybe that's one group you want to test. But patients who are overtly symptomatic with exocrine insufficiency, it is not recommended to check for fecal elastase 1 in this group. Now coming back to the ones that we have diagnosed it, how do you replace the therapy? Now, the replacement, of course, is pancreatic enzyme replacement therapy. There are certain things that need to be ensured when you apply pancreatic enzyme replacement therapy. One, the granules need to intersperse well with meals. They should resist inactivation by the gastric juice, empty simultaneously with meals, and release enzymes in the duodenum. To get this effect, most of the PERT formulation have to be pH sensitive, disintegrate rapidly at a pH of 5.5 in the duodenum, must be entry-coated to protect against gastric acidity, and there's recommended a microsphere size of 1 to 1.2 millimeters to be more efficacious so that they can exit from the stomach easily. Now in India, we have multiple brands. We have these brands on the left-hand side. I'm not naming them, but you can see the different types of strengths. More importantly, what you see is all of them have different units. Some are in USP units, some are European units, some is FIP units. And thankfully, when it comes to lipase content, all of them are interchangeable. So you can use, if a brand is USP of 10,000 is interchangeable with a brand which is saying an FIP of 10,000. However, if you want to give for amylase and protease, you need to put in a correction factor of 4.5 and 62.5 respectively to accommodate for this. So, if you look at the guidelines, most of the guidelines recommend a very high dose of lipase. And unfortunately, we do not have any good data from in our country as the amount of lipase required for pancreatic exocrine insufficiency. Now, these are, of course, the Gastroenterology Society guidelines. The ACC guidelines say that with each meal, you have to give 40 to 50,000 USP units. The UK consensus guidelines say that with the snacks, one has to give 25,000. With the lunch or major meals, 50,000. Similarly for the American Gastroenterology Association. So very nice study done by one of our collaborators, Dr. Whitcomb, had shown that if you use 500 units of lipase per kg per meal is good enough to manage patient's steatorrhea. So for a 50 kg individual, around 25,000 international units is good enough. Whereas for snacks, it is recommended to give 250 units of lipase per kg per snack. So how do you assess response? Once you've started a patient of pancreatic enzyme replacement therapy, how do you assess for response? The most easiest thing to look is for normalization of nutritional parameters, symptom resolution. Some societies recommend nutrition and testing for fat-soluble vitamin deficiency. Most of our practice has been looking at anthropometric markers and symptom resolution. And we titrate based on the symptoms, weight gain, and whether the patient develops any overt symptoms of fat-soluble vitamin deficiency. So when we looked at our subset of patients, a certain subset of patients were not responding to pancreatic enzyme replacement therapy. So the question came in, we added on proton pump inhibitors. Despite that, there was not much response. So then we turned to look whether there was a component of bacterial overgrowth in this group of individuals. So in a subset of 48 patients with chronic pancreatitis with exocrine insufficiency, we aspirated the jejunal aspirate. What we found is we have colony counts of upward to the tune of 38 to 40% in patients with chronic calcific pancreatitis. That means there's a high prevalence of pancreatic, in chronic pancreatitis of small intestinal bacterial overgrowth. And this probably is one of the reasons to develop resistance or non-response to pancreatic enzyme replacement therapy. Subsequently, most of this was anaerobic and aerobic bacteria. Only one had pure anaerobic. Subsequently, most of the guidelines have now gone on to treatment non-response by adding on PPIs and treating bacterial overgrowth. So if in patients who do not respond, a course of rifaximin or metronidazole may help in improving the response to pancreatic enzyme replacement therapy. Now, one of the major limitations that we face in our country has been the cost of pancreatic enzyme replacement therapy. And if you look at the cost per se, the average cost hovers between, if you give Creon, which is the gold standard medication, in India it costs around 9,000 rupees for a patient per month, which is extremely high. And even for the lower cost ones, like the ones in Serotan, if you give 3 tablets per day, the cost comes to almost like 4,000. So the biggest rate limiting problem with administration of pancreatic enzyme replacement has been the cost of therapy. And this is a fantastic study done by one of my friends from Calcutta, which showed that in patients with chronic pancreatitis, they have catastrophic health care. And what they mean by catastrophic health care is that when the health care cost exceeds more than 40% of the monthly income. And 76% of the patients did have catastrophic health care. And one of the factors, or in fact the most important factor which added on to the catastrophic health care of patients with chronic pancreatitis has been treatment with pancreatic enzyme replacement therapy. So to summarize, I would say we would need more studies in India to look at the right dose of PERT for our patients and our diet. And of course, we need industry support to mitigate the cost burden of pancreatic enzyme replacement therapy. Thank you so much for patient hearing.
Thank you very much. We can have 5 minutes of discussion on the first 2 topics. Can I invite Dr. Riddhi Dasgupta to...
Sudipta, I have a question for you. You mentioned that there are false positives in terms of the stool elastase. What could be the potential, because we have more of physician, diabetologists and endocrinologists here. What are the potential false positive as a physician or an endocrinologist or diabetologist? We really need to look into that before interpreting the stool elastase.
So false positive primarily happens when you have a diarrheal stool. If you have a loose watery stool, the fecal elastase would be low. So it's not recommended to send such samples for testing because invariably the reports would be low. So in a patient with diarrhea, if you're trying to look at pancreatic exocrine insufficiency, fecal elastase is probably not the right test. What the labs can do actually is lyophilize the sample and freeze dry it so to reduce the fluid content, and that might improve the sensitivity of the test. The other thing is when there is bacterial overgrowth. Bacterial overgrowth also tends to produce false positivity. And especially in diabetes, when there is a risk of bacterial overgrowth, that tends to produce false positivity. So fecal elastase, unfortunately, is the only good test available right now within the world, but it's not a great test for pancreatic exocrine insufficiency.
So where do you, I have one other question. Where do you rate the fat globules under the microscope? Because we have, if you look at stool elastase is not freely available, one, and it's expensive. So maybe in a primary healthcare center where you have a microscope for looking at the complete blood picture, if you have a system, what do you rate a fat globule test?
Look, if you ask a hardcore pancreatologist, they'll probably say, no, don't do it. But as in a resource-limited situation, suppose you're in a mission hospital and the easiest test that you can do is a stool. Only thing to ensure is that the patient has taken a good fat diet the night before to ensure that the stool has adequate amount of fat globules. That's, I think, is more important.
Sure, thank you so much.
I think from what you described, the elastase test should be interpreted in the context of the clinical situation.
Absolutely.
And I think that's a take-home point. If somebody has other suggestive features, then a positive stool elastase adds credibility to a diagnosis of pancreatitis. But by standalone, I don't think it's a really very good test for pancreatic exocrine deficiency.
I agree with you completely, sir.
If there is no question from the audience, I can take one question. Yeah, thank you very much.
Riddhi, how do you explain ketosis resistance with high glucagon level?
Yes, so again, that's not something which goes against the traditional viewpoint. As we have shown, and looking at the literature published by Dr. Mohan in the 90s also, it is not that in the entire spectrum of FCPD is ketosis resistant. He has reported up to 15 to 16% ketoacidosis, out of which he had reported 19 patients with ketosis, of which some 3 were ketoacidotic. In the study which I showed, which we did at West Bengal, we found around 11% patients. So it could be similar to what we have found with a hypoglycemia unawareness. It may not be a uniform phenomena. There may be something driving the glucagon secretion, maybe the upregulation or something else from the pancreas. People who have that level of elevated glucagon are probably having a different metabolic reaction or metabolic expression than people who do not have that level of glucagon, despite both starting out with the same tropical pancreatitis.
Thank you.
I suppose despite the high glucagon levels, certain amount of circulating insulin might be sufficient to prevent ketosis. That may be an answer to that question.
And also, I think Professor Yajnik's study was done, which showed that it is more to do with a defect in the hepatic ketogenesis rather than glucagon being a major factor. So we may look, he challenged these patients with medium chain triglycerides and then looked at the ketogenesis. So there may be subsequent pathways that may explain the ketosis resistant and not merely the presence or absence of glucagon.
I'm going to speak about something very different. I'm going to speak very much about single cells in the pancreas and what they do. Before going into the topic, I want to just announce something. So we are going to organize a conference in August 9th and 10th. Please mark the calendar there. So it's a primer conference with IDF support that would happen in IISc Bangalore. So please be present. We'll follow up with more details there. So just to give a little bit of background, I know this background is not required for this audience, but I still go through this. So when you're in a fed state, there is an increase in glucose, which leads to glucose uptake in the pancreas, which leads to insulin being secreted. That helps in glucose uptake in all the peripheral tissues. So there are two problems normally in case of diabetes. One is insulin resistance, which people extensively study about. The other is islet cell dysfunction. So islet cell dysfunction, not much was studied when I took this up, let's say almost a decade ago, but now there is a lot of stuff that's being done there. So most of the work that I'm going to present here is regarding islet cell dysfunction. So when you look at islet cell dysfunction, the pancreas in general has islets, which also has green cells, which is insulin secreting beta cells there. So these insulin secreting beta cells, they have a large number of granules which are present. So you can see that when there is an increase in glucose, there is increase in glycolysis and things like that, which leads to these granules fusing to the plasma membrane of the cell to release insulin. So these granules is what has been our interest area, and this is what we study quite extensively, and this fusion and how this fusion is led is what we study. So we do this using several high resolution microscopy techniques, so we can study single cells at a very high resolution. So some of the techniques are confocal microscopy, which some of you might know very well, and we also use something called turf microscopy. So the advantage of doing this with turf microscopy is that the image that you see on top that you see there, so you see the insulin granules which are fluorescently labeled, and you see them as dots that are there. So you can see single cells, and these granules are present there as single units that you see as dots there. So in a confocal micrograph as well, you can see these kind of granules, but they are very much at the periphery, and what is at the center is the granules which are present in the cytoplasm of the cell. So we are mostly interested in the membrane, where the fusion of these vesicles happen to the membrane to release the content. So just to give you a perspective of why we do this, in every individual, in a single beta cell, there are around 9,000 granules at a given time point, such a large number. And if you go across and just go through and see, there's only 100 of them that secrete at any given time point, very few in fact. But if you try to correlate this with insulin secretion, which is the biphasic response in the peripheral blood, you can't really find answers to what is happening with 9,000 versus 100 that is present at any given time point, which is secreting. So this was the question that we went after initially. So when we did this, we tried to see what are the granules which are present closely to the plasma membrane of the cell and what they do. So to study this, we had a setup where we could do turf microscopy. So we could have the islet cells that we could put it on a cover slip on top. So and then we can fluorescently label them. And we try to mimic the environment that we see in the pancreas, where we stimulate them with glucose. So when you do that, what happens is something like this. So you see a large number of granules that are present, and a few granules that are present there, they fuse to the membrane, which is represented by an increase in fluorescence, and then they start disappearing, as you might have seen there. So this also means that if you see individual events, it looks something like this at the bottom panel there, where there is an increase in fluorescence and they disappear completely. So the opposite of this is, when there is an increase in fluorescence and a disappearance, there should be appearance of a new one which would dock there, which is what is represented in the strip that came out just now. So this is what we are trying to answer, trying to see how many of them fuse to release insulin in a single cell, and how many of them are being replenished at a given time point, based on your fasting and fed states. So if you look across, we had access to human cadaveric islets. So this was when I was in Oxford and then was later in Sweden. So we had, so we used these islets from human pancreas, and then we put them on the cover slips. So exactly the experiment that you saw in the previous slide was done on this. So there was glucose stimulation that happened. So we tried to see the total number of dots that you see before stimulation, glucose stimulation, and later after stimulation. So if you try to see that, then you see the number of fusion events at any given time point after a glucose stimulation. So we try to plot this across many cells. So each dot that you see is a single donor. So each donor is an individual that you see there. So you see the white ones, the white dots there. They are all the individuals which are non-diabetic. You can see that the number of dots or the density of granules that you see on the y-axis in the left, they correlate very well with the insulin secretion that happened with the single cells there. But you see the lower panel there, which are the dots which are red in color. those are the diabetic individuals, and there you see the lower density of dot granules, which means there is less exocytosis. So what we try to do is we try to do with many different donors, and each dot again is a donor there. What you see is that in each case, in the type 2s, you see that there are fewer number of dot granules that we documented. So this was not the case in the non-diabetic individuals. So we try to see this in the biphasic response. This is the biphasic response on the left, which is from the peripheral blood. If you see in the single cells, what you see is you still see a biphasic response from the single beta cells, and then you see the type 2s there. You don't see any biphasic response, as you can visualize there. And correlate that with the number of dot granules, the number of dots that you see in the microscopy field, which I explained in the previous slide, and you can see that they do come down, which means there is a need to replenish this, and that is not exactly happening in case of type 2 diabetes. This was one of the things that we went after much further. So before going into this, we were also looking at glucose, because always we say glucose stimulated insulin secretion. So can we do something with glucose itself? Can we play with glucose? Was the initial question. So one of my PhD students in the lab, Pallavi, is looking at glucose, GLUT transporters. GLUT transporters are the ones which take up glucose in the pancreatic beta cells, and you can see from the right panel there that in case of type 2 diabetes, there is less expression of GLUT transporters in the first place. What this means is that there is less of GLUT transporters which are recruited to the plasma membrane of the cell, which means that there is less possibility of it taking glucose. So what we are trying to see is this a sort of cause for what I was trying to describe later, where we had less secretion and less number of granules that you see in the case of the beta cells. So to understand this, we are still going on. So that cartoon basically says how the pathway goes with the glucose there and the exocytosis which you see in the bottom panel there. So does the GLUT transporters answer our question with the granules is something we are yet to finalize. We'll see how it goes. So as of now, what we think is that the GLUT transporter recruitment is very critical, and there is endocytosis which is involved, and every time there is glucose being transported, there's endocytosis of these transporters. So can we play with this is what we are seeing. One of the compounds that we tried with a large screen that we did is FIO4-BIDA. One of the postdoc from the lab did the screen there. So FIO4-BIDA is a chlorophyll based compound. It is used in Madhurakshak active, which is one of the formulation used to treat diabetes, in fact. So from this, we did an LCMS and all that, and we arrived at this. So what we could see from this is we can arrest or we can keep the GLUT transporters at the membrane for a very long duration, which means that there is more and more glucose that individual beta cells can take up, which means they can metabolize glucose much better. So on the other context of it, we didn't really see a more recruitment of dot granules, so we don't know what else is wrong. So that's why we went after a lot of other things later. So just to summarize this part, biphasic response is triggered by glucose uptake into individual cells, and this glucose uptake can recruit the individual granules that you see there in green to the plasma membrane, which is very critical for the exocytosis to happen. So that's what is described in the first part of the summary there. So I'm telling you about insulin granule docking, which is the granules coming from the cytoplasm of the beta cells to the plasma membrane. So what exactly happens? Can we play with the mechanism here to make sure that there's more and more docking? GLUT transporter, even if you modulate it, trying to increase docking would be the second step is what we were after. To understand this, we went after many proteins. So one of the protein is called syntaxin. So syntaxin is a membrane protein. You see that on the right there, on the cartoon there, that you see syntaxin which has a membrane tag there. So when you look at single molecules of syntaxin, what you see is something like this. You see the green ones which are syntaxin there, and the red ones which are insulin granules there. What you see is that the syntaxin molecules, when the granule comes to the membrane, they try to decorate there and then they capture there. So they capture the granule at the plasma membrane, which is very critical for this to happen, which means that there is docking that takes place. So there is replenishment of docked granules. So there is more of granules that can come there. So this means that what part of syntaxin is what we went after. This one of the domains of syntaxin. I'll not go into the details in the interest of time. But what happens once the syntaxin is recruited? Once the syntaxin is recruited, there's other proteins which get recruited. It forms a sort of lipid raft and protein-based complex at the membrane which recruits other proteins, which is what is depicted here: MUNC18, MUNC13, calcium channels, etc. So we saw how the time duration of this is and how it gets altered. So we also saw that apart from syntaxin, there is also calcium channels which don't recruit properly in case of type 2 diabetes. So to summarize this part, we understood that syntaxin is important, and after syntaxin recruitment, other proteins are being recruited, which means that the granules can be present there, docked, so that when there is a glucose stimulation, there is exocytosis that takes place. So this complex is very important. Once this complex is formed at the plasma membrane where the granule is ready with all the proteins there, they can undergo exocytosis. So this is what is exocytosis that you can see there. There are many other proteins that I don't want to describe again in the interest of time. Just I want to show you that there are so many proteins involved just for a small process to take place. The recruitment of this at different time points really makes sure that the process kinetically is kept in phase. If that is not the case, then insulin secretion cannot happen. This can happen at various levels is what I'm trying to say. So this also shows regarding syntaxin and calcium channels, etc. So when this fusion happens, there is also number of granules under the stimulatory conditions with glucose which do not fuse. There are a few granules which fuse, like you saw in the movie there, and there are some which do not fuse. So those are called failures that you see on the right channel. So what we are trying to see is, can we stimulate these failures in case of a type 2 diabetic setting with 3 or 4 by day? So we could do that, but not to the extent that we wanted to recover completely. That's where we are. So we also are looking after if this is only protein dependent or also lipids are involved in this process. So yes, there are lipids involved. Phosphatidylserine is one of them. There is also PIP2 which is involved. PIP2 is an abundant lipid which is found in any membrane for that matter. If you look at PIP2 and if you try to see PIP2 using a probe, one of the PhD students in the lab, Aishwarya, is doing this, combining amperometry, which is a very complex technique to do with imaging in parallel. And what you see with PIP2 is whenever the single beta cells release insulin, you see the hotspots that are formed there. Those are the PIP2 hotspots that are formed. Exactly at the place of fusion, you see these hotspots being formed. Trying to make our story much complex, saying there's not only proteins but also lipids involved. And what these lipids do is something we want to understand, and the proteins involved and things like that. So where are we going towards with all this? We are understanding that there are proteins involved, there are lipids involved, but where do we go with all this and what happens in case of type 2 diabetes? So when we look at cadaveric tissue and we look at many of these proteins that I'm describing, many of these, the expression of them might be dysregulated to a certain extent. But apart from the expression, there's one more thing, which is they are not placed in the right place. They're not decorated to the place where the docking happens, which means the secretion is completely compromised. So there is sort of a melanodomain which is compromised there. So if you look across various proteins, if you take a type 2 diabetic islet and try to overexpress many of these proteins, you can recover the total number of dock granules to a large extent, which is what is depicted there in case of syntaxin, one of the proteins there. All of the proteins also true in this case. On the reverse, if you look at around 200 donors in this case, and if you look at the insulin secretion index of these individuals and try to correlate the insulin secretion index with the expression of these proteins, so many of these proteins are dysregulated in the sense that there is less expression of these proteins. On top of this, if you do an inverse correlation, the HbA1c would be higher for the individuals who are diabetic, correlating with the less expression of these proteins. Meaning to say that looking at these proteins would lead us to something is what I'm trying to impress upon you. So with that, I would like to summarize this part by saying that many proteins are important for this decoration to take place, and the expression of this is one important thing, and also it being recruited to the place where the granule has to undergo exocytosis is also very important, and these are all at many levels dysregulated in case of type 2 diabetes. So basically the granules coming to the membrane and then docking there, basically fusing to the membrane, and later undergoing something called various proteins being recruited during a priming phase is very important for the exocytosis to take place. In case of type 2s, they are decreased. So what does this mean? How can we rescue this whole process? I told you about some with the screens, the compounds that we have identified, but we also went after the cells itself to see if we can find answers there. So when we look at it, any cell for that matter, especially a diabetic cell, there is ER stress that is happening there, which means that in case of ER stress, there is also islet amyloid which is present. So these islet amyloid, they go and then form misfolded proteins in these granules. So basically making these granules non-functional. How can we approach that was the question we also tried to see. So with that, we also looked at two kinds of vesicles. To break down amyloids, there is something in the system, which there's nothing external, which is the microRNA which is present. So these microRNA are secreted from something called extracellular vesicles. So the extracellular vesicles are also present in the beta cells. And there was a study which came out in 2020 showing that the extracellular vesicle secretion is also reduced in case of type 2s, which means that there is more amyloid leading to less granules eventually. So there's a whole concept that we saw there. So then we started saying, why is it that there is less of exosome secretion or extracellular vesicle secretion? How can we address this? What we went after. So to do that, we had to label these extracellular vesicles in the beta cells. So to do that, we used a tetraspanin label, which took some time, but we arrived there. And we had to validate this to see isolated extracellular vesicles, which Priyadarshini, in collaboration with Vidya from in the institute, she is one of the PIs there, we could validate this, and we saw that in EM micrographs, we could see the granules, and we could see insulin granules, which are separate, and extracellular vesicles, which are separate, and we can separately label the extracellular vesicles in the same beta cell. So with that, what we saw also was that we could mimic what was seen at in the peripheral blood, that there is less extracellular vesicle secretion from beta cells. So we could see from individual islets from human donors that there's also less extracellular vesicle secretion. So what we are going after is that with this probe, trying to see what is wrong with this extracellular vesicle secretion. So just to impress upon you, the extracellular vesicle secretion also looks very similar to sort of insulin granule secretion, but you see there are very few numbers that you see there, and you see fusion events that come up and go very fast. Now we are at a stage where we know of two individual vesicles, and both of them can somehow hopefully improve insulin secretion is what we are thinking, which means to say that in the microscope we are basically, I tend to tell my students, we are seeing stars, and those stars would lead us somewhere. So in the screens we have some compounds. We want to see how this would lead us to improving insulin secretion at various levels, at glucose transporters, at the level of extracellular vesicles, and at the increasing the number of top granules. So we'll see where we arrive. Hopefully in the next meeting I'll be able to tell you more about this. So with this, I would like to end my talk with thanking all the granting agencies and the group which did all the work. They are the ones driving the story. I'm just sitting and getting the grants. That's what I say.
The question is, you talked about blood dysfunction in patients with type 2 diabetes. Do you have the A1Cs of those patients?
Yes,
and could this be a secondary phenomena due to glucotoxicity rather than a primary phenomena?
So we have looked at glucotoxicity as well. So there is a reason to believe that it could be a secondary phenomena. But then on the other hand, most of the drugs that we use is also trying to, let's say, GLP-1 analogs and things like that. We have also tested those. So those we wanted to see, do they bring up docking or priming or something like that? They do help to a certain extent. So we are trying to see at the individual single cell level, can we treat the sort of consequence rather than the cause? I'm not saying this is the cause at all. So it could be a consequence.
So potentially working at a, at a deeper level, you may be able to delay insulin therapy, etc.
Yes, that's the idea behind all this.
Right. Yeah,
So the idea is to just make sure that to drive the cells which are left over in the pancreas, to drive them to so that they can secrete, so you can revive them is where we are trying to work on.
Sure. Thank you.
Thank you.
The beta cells from type 2 diabetics that you studied were from what kind of, were they human cells or?
Those were human cells. So we study in 3 model systems. In fact, we normally use mouse cells when we don't get human cells.
Okay, easy.
So when we do get human cells, those are cadaveric donors. So when we get human cells, those are cadaveric donors. So we depend on that from Europe and also from Canada. So it's very hard to get them here. So we are right now just getting sort of fixed samples. So for live samples, we depend on the mice and we isolate the tissue from there.
Type 2 diabetes model in mice.
So that is mostly high-fat diet induced Secretory and high-fat diet combination from the mice.
Is there a difference in the docking proteins?
Yes,
In
we
the
do.
early stages of diabetes in these mice as compared to later stages?
So some of the proteins that I alluded to, the syntaxin and SNAP25 and things like that, we do see a difference. and it's already published that there is transcription factors, which are also risk genes, which is TCF7L2. They do control the expression of these proteins, is what is being said about that.
Is it related to the duration of the diabetes in the mind?
So these are, if you see in the sort of initial few days, you don't see any change. But then when they are really, like when you do a sort of glucose tolerance test, and when it's really high, that is when we do see the change in expression. It's quite late, in fact.
Okay, thank you.
Nikhil, that was beautiful talk here. It's Felix here. Nikhil, I have one question. You mentioned that glut, which subtype you actually looked into on the pancreatic cell? Is it GLUT1 or GLUT2?
So these are both GLUT1 and GLUT2 is what we have looked into. So what you see mostly is that in case of mouse, it's one of them. I think it's GLUT2, and in case of human, it's GLUT1. So we try to do that based on if we have mouse, then we go for that. And
yeah, that's what. And also you mentioned that you added metformin and try and see whether there is a recruitment of GLUT1. I mean, that's very new for us to understand.
So metformin has been known for a long time that it helps the GLUT transporter. So it's not new, in fact. So we tried to pick up something which was there in the literature, so we can compare our compound FIO4-BIDE.
But you mentioned GLUT1, that's why I was a little surprised to see that.
Yes, in that case, it was actually mouse cells. That's why.
All right. Okay. So humans are a little different from, in fact, GLUT. Yes. It's not the GLUT1, so that's why I just want to clarify.
Right. So those were mouse cells.
Yeah, sure. Thank you.
Thank you, Felix, and I'm very grateful and deeply honored to be here. Thank you to Nikhil, Felix, and the whole team for giving me this opportunity to give this talk. My wife and I spent over 2 decades here in CMC, and this is like coming home, so it's a remarkable institution, and I'm so happy to be here and to be invited. So I work as a pediatric transplant surgeon at Sydney, the Children's Hospital. It's associated with the Adult Hospital, and we are one of 2 units in Australia that do islet transplants, both allo and auto transplants. We've heard a lot about chronic pancreatitis, so I'm going to skip through slides. The procedure that I'm talking about is really for chronic pancreatitis. We know that chronic pancreatitis is a debilitating disease associated with a lot of pain. The pancreas gets scarred, the acinar cells go, the islets go, and then there's also a long-term risk of malignancy, as was presented with that case in the beginning. So that's all the loss of acinar cells, but interestingly, the islets seem to survive much longer. But the real problem with chronic pancreatitis is pain, and especially for children, it's terrible. They often have narcotic dependency by the time they come and see us. The effects of chronic pancreatitis is multifactorial across multiple domains. There's mental health issues, school absences, the family is disrupted. The pain is so bad that by the time they come to us, they're actually little drug addicts, and when they're older, much more so. Of course, there is exocrine and later on endocrine dysfunction as well, but also a long-term risk of pancreatic cancer. So chronic pancreatitis is an adult disease, but I think an alcoholic pancreatitis seems to be the predominant factor, but although in India, I suppose FCPD would play a very prominent role as well. In children, it's predominantly genetic, and there's a consortium called the INSPIRE consortium that looks at pediatric pancreatitis, and 73% of children with chronic pancreatitis have an identifiable gene. Most often it's the PRSS1, about 50% of them. Hereditary pancreatitis or gene-related pancreatitis, occurs because there's inactivation of trypsin, or there's too much of production of trypsin, or trypsin doesn't get excreted, and then you get persistent damage. In our cohort in Australia, we have a large Aboriginal population with chronic pancreatitis, and 100% of them have the PRSS1 gene. Now, I like medical history, and I'm going to divert into a little bit of interesting medical history, which is almost 100 years old. Many of you would recognize Banting and Best, but I like Banting because he was a surgeon like me. And he was a struggling surgeon. He had no patients, actually. And to make ends meet, he started work as an anatomy tutor. And one day, while he was preparing for a talk the next day, he read this article in Surgery, Gynecology, and Obstetrics that talks about various diseases of the pancreas. And the article described chronic pancreatitis, and it was related to, duct being blocked, so stones and calcification. And the article went on to say that the acina cells go early, and then they get digestive enzymes are not there, and eventually the islets also go, and then they get diabetes. So being a surgeon with surgical logic, he put 2 and 2 together, and he said, oh, it must be the islets that produce that factor that regulate sugars. And so he had this nice, interesting experiment, again, surgical logic. He took 2 sets of dogs. One, he took the pancreas out, made them diabetic. The other set of dogs, he tied off the pancreatic duct and induced chronic pancreatitis. And once the acina cells had come off, he extracted the juice out of the pancreas, which actually contained insulin, injected into those diabetic dogs, pancreatized dogs, and demonstrated that the glucose levels came down. Now, 100 years later, and you know that Banting, he got the Nobel in a couple of years, and there's a lot of interesting story around that. But 100 years later, we are actually replicating what he did for chronic pancreatitis in a sense when we do total pancreatectomy with islet autotransplant, except it's not the insulin, it's the islets. And what we do in this procedure is we remove the pancreas, and we have to remove it like you're doing an organ transplant. So people like me who are transplant surgeons will remove the pancreas, keeping it alive for as long as we can. And the islets are extracted. The extraction process can be quite tricky, and you need skilled people to do it. Once the islets are extracted, you put it into a bag, infuse it, usually into the liver. The liver is the best bed for it. It embeds within the sinusoids of the liver, engraft, establish its own blood supply, and then start producing, like magic, endogenous insulin. So this is, I've got permission to show these pictures and tell the stories of some of my patients. This is a child who came from Queensland. She was 9 when she came to us, but she'd been having pain for as far as she can remember, definitely from 3. And she had stock standard chronic pancreatitis. The problem was the pain. It was terrible. She'd already been on Creon, and by the time she came to us, she was already on oxycodone and clonidine. Regularly almost, and every time she was in the hospital, she was on morphine and fentanyl and ketamine and everything you can imagine. We managed to take the pancreas out, and that's what it looked like. It was very hard, small, and scarred for a small child. You can see the scarring, and you can see the duct dilatation. We were able to get a reasonably good amount of islets out of her, about 6,000 islet equivalents per kg. She did really well in the sense that she came off insulin in 14 months, and 4 years later, she's cured. No pain, not on insulin. So for her, this was life-changing completely. So when we do surgery, what we do, as I said, you need transplant techniques to remove you do a total pancreatectomy. In North America, where they have the largest experience, most patients also have the spleen removed. We in Australia tend to preserve the spleen because we think there's a benefit to it. The bile duct is reconstructed like this. And when you preserve the spleen, you can see you can do it safely without compromising the pancreas. That's the splenic artery and splenic vein and portal vein. We take it out, and this is what happens in theater. Apologies to all the physicians in the room for these glory surgical pictures, but that's a duodenum that we remove. It's preserved and cleaned and cannulated with some digestive enzymes. The pancreas is actually broken into little bits, and Bala, this is your paper, and the islets are extracted. and then brought to us. And it takes about 4 hours for them to isolate the islets and bring it back to theater. But extraction can be hazardous because, you're digesting the pancreas with harsh enzymes, there's mechanical disruption. The islets are subject to lots of stresses, oxidative and osmotic stresses. And, you do need to do it properly and try and keep them alive and get as many as you can. Now, I'm grateful to Bala. He's the next speaker for giving me these slides. Bala works at Columbus, Ohio. When you take out pancreas from a disease, from chronic pancreas, very different from taking islets out of a deceased donor pancreas that comes from a cadaver or a deceased donor. It's really hard, and it takes a lot of skill to be able to get a good number of islets out of it. Bala will be speaking, and he's given me this slide as well. He's done more than 500 islet autotransplants. And what I really like is that Bala, actually I knew Bala over 20 years ago when he was here in CMC. I used to go and do some animal work in the physiology lab, and he was doing his PhD in xenotransplants, islet xenotransplants, more than 20 years ago. And we are very proud of what he has achieved now, and looking forward to his talk. So when the islets come out, they tell us the volume, the weight, the total number, the purity, and also we calculate the islet equivalents per kg. So if you have 100,000 islets and you have a 10 kg patient, you get about 10,000 islet equivalents per kg, which is pretty good. Generally, some of these slides are with the equivalent of Bala. It's given to me by Wayne Hawthorne, who is a scientist who does it for us in Sydney. And generally, if you get more than 5,000 islet equivalents per kg, that's good. These are what good islets looks like, and those are what bad islets looks like, and you want to get viable islets and lots of viable islets. The thing is, you do lose a lot of islets in the process. The islets come in a bag like this. We put a cannula into the portal vein. Usually I do it through the inferior mesenteric vein. This is the nurse infusing it into the liver. We do it very slowly. We give lots of heparin to prevent a thrombosis, and we also check portal pressures regularly to ensure the pressures don't go up too high. The islets go again, embed in the sinusoids, and establish blood supply. Now, gastric emptying is a real problem. After that, it takes a long time for gastric emptying to be well established, so we often put gastrojejunal tubes. Some people put jejunal tubes. Most of the times, we put a transpyloric tube and drain the stomach out like this. Now, keeping islets alive, I think it takes about several weeks to 3 months for the islets to fully engraft and revascularize in the liver. But getting the maximum number of islets and keeping them alive is, I think, the big thing if you want to have a successful islet program. So getting a transplant surgeon to remove it so that you don't kill it. In the process of removing it, get as much as possible. But it's very important intraoperatively, perioperatively, and postoperatively for at least the first several months to have very tight euglycemic control, because hyperglycemia stresses the islets and you get beta cell apoptosis and death, and you won't survive. So we have, with each islet transplant we've done, refined our protocol. So we have a very tight protocol that we use in Sydney, and our endocrinologists built this. There's an algorithm that is followed to ensure that we keep the sugars within a very tight, narrow range. So we don't like these big hypers, especially. So the question is, how good is it, and is it really worth doing? Because, it's obviously a very big deal for these patients. This is a paper that came out of Minnesota about 10 years ago. There's new data, but I think these graphs actually tell the story. They had done 75 children at that time, and you can see that the pain relief, narcotic use is significantly lower. Pain relief is very significant. Insulin independence, about 40% of children became insulin independent by 3 years. But if they were younger, so between 5 to 12 years of age, they gained insulin independence much earlier, but also many more of them became insulin independent. So, and this insulin independence is sustained over a 10-year period, which means the beta cells that are, or the islets that are in the liver don't die, they survive. Now, the other thing is, from a quality of life point of view, you can see that these children are back to normal lives. They're not missing school, and they've got their lives back, or patients. This is a paper we wrote about, many years ago. At that time, in 2020, across Australia, we had done only 16. We've done many, many more since then. And we done, the median age was 22. Our oldest patient was 50 and youngest 4. Most of them were hereditary pancreatitis, and half of them had their spleens preserved. We had a 50% insulin independence at the median age of 24 months. And insulin independence was directly related to the number of islets we get. And the younger we get them, the more islets we get. And if you compare the Australian experience with other units around the world, I think most of the experiences from North America, a little bit from Europe, and now in Australia, they're all about the same, about 40% insulin independence at 2 years of life. 2 years. Now, the other thing to note about what happens to glycemic control is that these are children with hereditary pancreatitis. About 60% of them at 4 years are insulin independent, but the others also have exogenous insulin, so they're not brittle diabetics. So they do have functioning islets, except that they're not enough to make them, they need some extra help. This is POST is a multi-center consortium to look at TPIT. There are 12 centers that contribute data to this, and they've accumulated 406 patients among these 12 centers. There are probably more around the world. But you can see that if you want to get good islets, you need to get them young. So older age, genetic disease, hereditary pancreatitis is a more severe disease, and you need to get them young. Perhaps FCPD is like that as well. The amount of atrophy and ductal damage reduces the amount of islets, and drainage procedures also reduce the islets. And the reason I'm telling you this is because you have patients with chronic pancreatitis. You might be thinking that this might be a suitable candidate for a TPIAT. It's better not to do a drainage procedure. That means better not to do, a Puestos or a phrase or one of the other procedures. Now, surgery is there. It's historically being done for chronic pancreatitis. You basically lay out the duct like this, and in the phrase procedure, you also core out the head of the pancreas, and you ensure that it drains really well, and therefore reduce the number of inflammatory episodes. Although, having said that, about 50% of patients who had a drainage procedure are known to have recurrence of pain long term. I found these two interesting papers in children which make an argument that there may be a good role for drainage procedure if TPIAT is not an option, or it might be a preferred option. So this is from Iowa, only 12 patients, an old article, more 25 years old, and it shows that the ones who had immunomodified Puestos, after 3 years, they had sustained, hospitalizations were reduced significantly. And this recent paper from Calcutta, 24 children with chronic pancreatitis, all had phrase procedure, 91 of them were pain-free. And this was a nice editorial when TPIAT was being touted. People, there's enthusiasm about it. It's about 10 years old in Nature Reviews, and this looks at TPIAT versus other surgical procedures head-to-head: endocrine deficiency, physical effects, emotional effects, narcotic use, sugar control, and mortality. And kind of similar, but as expected with endocrine insufficiency, a little bit more with TPIAT, narcotic use, a little less with TPIAT. Now, for children, you need to balance risk, and I think in your own context, you also need to know what to do. So you can see that Mila, who I talked about, had a pump, closed loop pump with her that she walked around with or lived with for about a year, and then she didn't need it anymore. This is another child that we did a gastrojejunal tube because of long-term issues with feeding. So there is a risk of diabetes. There's risk of ongoing pain. If you do a drainage procedure, you might not cure the pain quite as well. And of course, there's also a risk of malignancy, as we sort of saw from the first talk. And of course the question is, the malignancy risk, if you do a drainage procedure, do you reduce risk of inflammation, and is it a modifiable risk factor, is a question that's not really answered. In hereditary pancreatitis, we know that pancreatic cancer actually begins to creep up at the age of 40 and then rises exponentially. And by that time, you already have, pain for a very long time, very likely pancreaticogenic diabetes, type 3 diabetes as well. So we looked at, this is a cohort from South Australia, and I'm very grateful to Toby Coates for giving me many of these slides. He's a dynamic physician who runs Islet program in South Australia and heads our Islet consortium in Australia. And we looked at 122 patients with hereditary pancreatitis, and they had 5 cancers. So when we talk to and counsel patients for TPIAT, we have to look at very strict criteria. We have to lay all the cards on the table. So there are Minnesota criteria which we generally use, but in the Cincinnati criteria, there's also the parents have to say that they are willing to risk lifelong diabetes. Now, there are some cases where there's no doubt that that's the answer. Like this report of a 2-year-old child who had chronic pancreatitis, had the PRSS1 gene mutation. This child had ascites and life-threatening bleed, hemorrhage. And so they took the pancreas out. It was only 2 years old. It was already scarred. They removed the islets. They got a lot of islets, 8,300 islet equivalents per kg. And she was weaned off insulin in 1 month. So that's a remarkable result, weaned off insulin in 1 month, and she remains, well a year's time. Now, this is a quote I got from one of my patients. We did this child about a year ago, not a year ago, about 6 months ago. When I called her early, just for how she was doing, just before I came here, Mom said, she said, "Mom, this is the first year of my life I'm going to live without pain." So this child had known pain all her life. So I think it's good to do. It's a good option. It's another thing that you should have in our armamentarium for chronic pancreatitis. You need to be selective about who you do it. I think getting islets and getting a good islet program or somebody like Bala and Wayne is very important. And you have to weigh the costs. Costs of ongoing follow-up and the risk of cancer as well. And I think the future will be that, what can we do to ensure that we don't lose so many islets in the process of removing them. And in, Banting's experiment, they refined how insulin was extracted. I think we need to do the same thing for islets. I think that's the next frontier. I'd like to acknowledge we're part of a very big team. The Children's Hospital is here next to the adult team, and the Islet program is in the research center in the center. We work very well together, and we work and our endocrinologists are very, very closely involved. You'll be happy to know. Thank you very much.
Thank you, Chairperson, and thank you, Dr. Gordon Thomas, for your kind introduction to soil, where I learned the islet isolation technique in this institution under the guidance of Dr. Gunasekaran back in 1993. So I never thought that I will be using isolated islet cells to cure diabetes in patients, and now I have done more islet isolation and gained a lot of experience. It's mainly because of the good foundation CMC provided to me. This was our first transplanted rat. We observed a reversal of diabetes in the streptozotocin-induced diabetes rat after transplanting non-human primate islets and a renal capsule with strong immunosuppression. We observed survival of the islet graft and kidney capsule with immunosuppression for a prolonged period of time. Thanks to CMC for providing a brand new laboratory to establish this islet transplantation work. And Dr. Gunasekaran and Dr. P. Zachariah trained me in islet isolation procedure. Really, I'm really thanking to both. And apart from that, we had a great funding support and faculty member support in our institute. Department of Science and Technology plus Christian Medical College Fluid Research Fund and Dr. Vishwanathan Research Fund available to us to do these experiments, and a lot of support from our Department of Physiology faculties, endocrine faculties, biochemistry and pathology. I'm really thankful to everyone. So Dr. P. Zachariah traveled to Washington University, St. Louis, Missouri in US, and learned the technique of islet isolation from the world expert, Dr. Paul Lacey, who is considered as one of the, who is the father of islet cell transplant. And Dr. Gunasekaran learned the technique from Dr. Zachariah and used the islet cells for various basic physiological studies and published these two key papers in those days in 1970s in prestigious Diabetes and Diabetologia journal. So I learned the technique and then started using islet cells for transplantation experiments, and now I have provided training to two Vellore candidates, Dr. Kopala Krishnan Loganathan. He worked with me for more than 13 years, and recently Neetu Prince from Department of Physiology. She is here in the audience today, and I believe this Vellore legacy continues. So whatever I learned from animal experiments, we translated into human clinical trials with the help of Dr. David Sutherland and Dr. Thomas East-Arsel at the University of Pittsburgh and the University of Minnesota, thanks to them. Why islet cell transplant? Insulin is not a cure for diabetes. Even the recent study from Type 1 Diabetes Exchange Quality and Improvement Collaborative Study, this paper was published in 2023 in Diabetes Technology Therapeutics, clearly showed 74% of the 48,000 people with suffering from type 1 diabetes do not achieve hemoglobin A1C targets of less than 7%. More than 30% of the patient, their hemoglobin A1C levels were greater than 9%, even after using the latest modern pump technology. So definitely islet cell transplant is necessary for providing the normal physiological control. Isolated islets of Langerhans are great source of cells for transplantation to cure type 1 diabetes and for understanding the molecular pathways involved in glucose sensing and insulin secretion by the beta cells, which ultimately help to design the treatment strategies for type 2 diabetes. Isolating islet cells from a human pancreas or larger animal pancreas like a porcine or non-human primate is somewhat a specialized technique because the islets are well buried inside the exocrine compartment. These are the isolated islet cells under dissecting microscope. They are from 50 to 500 microns. These islets are stained with the diophenyl thiocarbazone. It's a zinc binding substance. We don't transplant just beta cell alone. We transplant the entire islet because we want to have a paracrine effect from neighboring glucagon secreting cells and somatostatin secreting cells. Once the islet cells are separated from the native pancreas, they are routinely used for islet cell autotransplantation, allotransplantation, and xenotransplantation, as well as for various research. Islet autotransplantation is primarily for, as Dr. Gordon mentioned, it is primarily for chronic pancreatitis patients, those who are undergoing total pancreatectomy. Islet allotransplantation is primarily for brittle type 1 diabetic patients, and the xenotransplantation of porcine islets to non-human primates with the aim of transplanting pig islets into humans. Actually, in 2024 was an exciting year for xenotransplantation field because genetically modified pig heart and kidneys have been successfully transplanted into humans, and islets are in pipeline. And isolated islet cells from type 2 diabetic donors are again great source of cells for studying the pathophysiology of type 2 diabetes. In islet allotransplantation, we accept brain dead donor pancreas from numerous organ procurement organizations throughout the country, and We bring the pancreas within 12 hours cold ischemia time and isolate the islet cells and do extensive quality control before we infuse the islet cells into type 1 diabetic patients. We infuse the islet cells into the portal vein so that the islets will embolize in the liver. Then now the liver will become like insulin producing organ. Before we release the islet cells, we do extensive quality control assessments like a viability, islet number, purity, endotoxin level, gram stain, 14 days microbiology culture, plus their insulin secretory characteristics. So it starts with the special procurement, transporting the pancreas, isolating the islet cells, and finally infusing the islet cells with the help of interventional radiologist to infuse the islet cells. For clinical islet transplantation, we process the human pancreas in a dedicated CGMP good manufacturing facility under strict FDA regulatory guidelines. Because in FDA's view, isolating islet cells is almost manufacturing a drug, because we don't want to introduce any contamination during the process. Islet isolation process requires 4 to 5 members continuously work for 5 to 7 hours to collect islet cells, depending upon the nature of the pancreas. If we don't do purification, naturally our time duration is very short. If we do for purification, like in brain dead donor pancreas, it takes really longer time. And the basic method of islet isolation is intraductal injection of enzyme collagenase to digest the pancreas to release islet cells. The enzyme collagenase basically breaks down the connection between islet cells and exocrine cells. Basically, the pancreas become a cell cluster at the end. This is the undigested portion of the ductal cells. We purify the islet cells based on the cell densities differences between islet cells and exocrine cells using density gradient in COBE 2991 cell processor. We use Riccardi chamber to digest the pancreas. From a 100-gram pancreas, we may get 2 to 3 grams of islet cells. Again, it's easier to infuse the islet cells with the help of interventional radiologist. It's eliminating these exocrine cells. Somewhat is a challenging procedure. We get like a massive amount of exocrine cells after islet isolation. This is one of our research area. We have introduced many different enzyme, collagenase protease enzyme formulation to digest the pancreas to release islets, because we want to maximize islet number from every processed pancreas. We need a different formulation for digesting severely fibrotic chronic pancreatitis pancreas, or if pancreas comes from obese donor or lean donor, older donor or pediatric donor, you need a different formulation. We have successfully introduced different enzyme formulation, and in recent times we have successfully used recombinant collagenase in constant collaboration with the enzyme manufacturing companies. And this enzyme is very powerful, and it's giving a better viability of islet cells. And using this ductal cells during the islet isolation process, we digest the ductal cells. Those ductal cells are commonly eliminated during the process. We collect them and try to reprogram those ductal cells to become a beta cell using a stem cell approach. Many institutions are using stem cells or iPSC derived cells to develop beta cells. Since we are having ductal cells during our islet isolation process, we try to use those ductal cells. Plus pancreas is a highly vascularized organ. During digestion process, we damage all those capillaries inside the pancreas. Those capillaries are released during the isolation process, but generally those cells are washed away. But we learned the technique to collect those microvascular fragment post-transplant with islet cells to enhance islet microcirculation after transplantation. Many times, we get research pancreas almost every day, in US. Many unusable pancreases are. One example is if the pancreas comes with a longer cold ischemia, we cannot use it for a transplant, but it is good for our research purpose. So we use those research pancreas, decellularize, basically remove all the cells and get the skeleton of this extracellular matrix, and try to use these extracellular matrix for recreating the home environment for islet cells. And we use many SOD mimic compound, because isolation is a stress process, as Dr. Gordon mentioned. we try to reduce the stress to islet cells by supplementing different SOD mimic during islet isolation process. Type 1 diabetic patients complicated by severe hypoglycemic unawareness and severe hypoglycemic episodes and kidney recipients are the ideal candidates to receive islet cells because they have to take immunosuppression at the end. Islet cell transplantation have done for over several decades. Actually, the world first islet cell autotransplants and allotransplants were performed at the University of Minnesota back in 1970. However, the major breakthrough came from University of Alberta, Edmonton, Canada. This Edmonton protocol was published in the year 2000 in New England Journal of Medicine. All transplant recipients were insulin-free for a period of 1 year with their protocol. 5 years after transplant, the insulin-independent rate significantly decreased after 5 years after transplant. However, there is a continued C-peptide production and restoration of insulin secretion from the transplanted graft that improved the quality of life and corrected the hemoglobin A1C and reduced the hypoglycemic episodes. The same trend was observed 10 years after islet cell transplantation in University of Alberta, and the transplanted graft survival was 73%. In recent time, last year, Edmonton group published this paper. They showed their 20 years experience, and among the transplant recipients, 8% of the patients, their insulin independent rate was 20 years, and in average 32% at 5 years insulin independent rate was achieved by Edmonton group. So over 5,000 transplants have been transplanted worldwide in Canada, Europe, and other countries. It's a standard of care. Government approves islet cell transplantation procedure. Unfortunately, in US, auto transplants are considered as a standard of care. Insurance companies reimburse for this procedure, but allotransplantation is still considered as experimental transplantation. We have been in discussion with the FDA to change the regulation of islet as an organ transplant. That's the way other countries are using this model. In FDA, they are considering islet as a drug because our raw material pancreas is different every time, so we cannot use that as a drug. However, every year we see large number of islet cell autotransplants and allotransplantation, continuously performed worldwide, and collaborative islet transplantation registry data showed after transplantation, it's almost eliminating the hypoglycemic episode. For example, this is before transplant and this is after transplant. So this is one of the main advantages for transplanting the islet cells for the elimination of hypoglycemic episodes. As blood glucose levels have well controlled after transplantation, it helps in preventing the development of secondary complication. Dr. Warnock group from British Columbia compared intensive medical treatment with islet cell transplant and reported that there is a real benefit in terms of diabetic retinopathy and kidney function. So we participated in this phase 3 clinical trial sponsored by Clinical Islet Transplantation Consortium, in which 10 centers participated. 48 patients received islet cell transplants in almost all the sites, and 87% of the subjects met primary efficacy endpoint as well as the secondary endpoint. The primary endpoint was achieving near normal hemoglobin A1C and free from hypoglycemic episodes. And there's another study, they looked at quality of life improvement after receiving the islet cells, because these diabetic patients, they accept to take the immunosuppression, and the study reported that both the diabetes distress level and the hypoglycemic fear levels were significantly decreased after islet cell transplant. This is another recent study from France. Trimeco Consortium reported that first they compared optimized insulin treatment versus islet cell transplant, and they reported that 80% of the patient achieved hemoglobin A1C level of less than 7 with no severe hypoglycemic episodes when compared to this is mainly kidney recipients. They're all this is all done as a islet after kidney, and if you compare 80% versus 0% in optimized insulin treatment group, the same result we obtained in phase 3 clinical trial of islet after kidney in US. Similar pattern after patients who have received already kidney with the immunosuppression, and they had a better glycemic control after receiving the islet cells. So University of Minnesota contributed to this field in many different ways. One of the remarkable accomplishment from University of Minnesota was single donor success. Most of the transplant recipients maintained insulin-free status for more than 9 years with a single dose of islet cells. In Edmonton trial, you are allowed to infuse multiple donor islets. Even you can achieve insulin independence with a single donor. 5 years insulin independent after whole organ pancreas transplant and islet cell transplant. As you know, the whole pancreas can be transplanted to do the same function. Very commonly, simultaneous kidney and pancreas transplants are very common in US. When comparing the 5 years insulin independent rate, this gray bar is islet cell transplant and the black one is whole organ pancreas. So we get a similar result. As you know, transplanting the entire pancreas involves major surgery. Infusing islet cell is a kind of easy procedure. And in recent times, Dr. Piotr Witkowski from University of Chicago, his team has been consistently achieving excellent islet function after transplant in islet after kidney patients, as well as in solitary islet cell transplants. This is one of the classical examples. His patient is completely insulin-free for 3 years with the perfect hemoglobin A1C after islet after the kidney. This is another patient, the blood glucose levels before and after transplant, and she received islet cells after kidney, and she has been maintaining insulin-free status for the last 2 years. And many of his patients, they are insulin-free for 4 years, 5 years, 9 years, 9 years, 9 years, and 10 years. So if we select the right donor, like a donor selection plus right procurement and less cold ischemia time, and using the all modern recent enzymes, specialized collagenases, we can achieve long-term insulin independence in many patients. Actually, 13 out of 14 patients are insulin-free in his continuous clinical trials. And this patient is insulin-free for 14 years. And his group is using a Raproxin therapy. It's a IL-8 blocker. Using this therapy, he achieves 50% insulin-free status in 5 years insulin independence. And this particular recipient, she is maintaining normoglycemia for more than 9 years. Her hemoglobin A1C is less than 6. She received a single dose of islet cell, and in between she had 2 pregnancies. Nowadays, many innovations are happening in islet cell transplant field. Especially the first goal is transplanting the islet cell without immunosuppression. So there are many tolerance protocols are established, and there are encapsulation technologies are available to protect the islet cells without giving immunosuppression. And instead of using liver, omental pouch plus muscular sites are available. And then cell source, I'm sure you all read about many papers. Beta cells, basically embryonic stem cells. From embryonic stem cells, it's easy to generate beta cell. From iPSC cells, we can generate the beta cells. those cells have been successfully used for a transplantation purpose. And then there are gene editing approaches, co-transplantation of mesenchymal stem cells along with the islet cells to improve the engraftment. And using the vertification technologies, this islet banking is available nowadays. To summarize, islet transplantations are effective both short-term and long-term, and mainly it eliminates the severe hypoglycemia and restores hypoglycemic unawareness. And mainly in many cases, it achieves insulin independence. And there are many advances are happening to increase the efficacy, safety, and supply. And I'm sure due to the availability of different type of donor, not only human donors, plus using the porcine and beta cell from stem cells derived beta cells, it's easier to transplant to many patients. With this, I stop. I thank my University of Pittsburgh, Minnesota, Louisville team, and organ procurement organizations. They supplied thousands of human pancreas to our lab or doing all kind of research, and the funding agency and my Islet core members. Thank you.
Good, thank you. Thank you very much for the introduction, and it's a real pleasure and honor to be here. This is a great session. Thank you, Vala. That was quite an overview of islet transplantation. So we're going to keep with the theme of islets, but I want to talk about new insights that have been gained over the last 10 years about human islets and their relevance to human diabetes. So this is the group that I work with. This is my colleague Marcela Bershova and some of our colleagues at the University of Pennsylvania and the University of Florida. I don't really have any disclosures for this, but I want to actually make some disclosures for our field, if that's okay. The first disclosure is we don't know what causes type 1 diabetes, and we don't know what causes type 2 diabetes. Even worse is we don't even know how many types of diabetes there are, right? So this is we have job security because we can't figure this out. And there's considerable heterogeneity in the forms of diabetes, and we often think of diabetes as a monolithic disease, but we all know that that's not the case. So I'm going to talk about some new insights into that. Other parts of that is we don't think about early life events. This has been a very interesting conversation we've had about environmental factors, nutrition, and those sorts of things. We know that things like socioeconomic status, and then finally, our disclosure is we treat everybody the same, even though we have new therapies and we can't individualize it. So I think those are disclosures for our field. Here's what I'm going to talk about today. We're going to talk about some approaches to study the molecular events in the human pancreas and islet. Some quote-unquote new aspects and some heterogeneity that's become apparent in type 1 diabetes, and some events and changes in the human pancreas in the first decade of life that impact diabetes risk. And finally, we'll talk about some identification of some molecular defects in early stage human type 2 diabetes. So, these are the organs that we all know about that maintain our blood glucose. And we know it's an incredibly complex system, but I think the conductor of this orchestra is the pancreatic islet. So that's where we're going to focus today. We know that if one looks at type 1 and type 2 diabetes, that there are, many loci for type 1 diabetes, even, hundreds and hundreds for type 2. Most of those loci point to beta cells, even though we don't know the specific gene that causes that. So the premise is that sort of I'm walking under is that beta cell mass or function are critical determinants of whether diabetes develops. All forms of diabetes. And so whether you want to call it beta cell mass or secretion, but really it's functional beta cell mass. And so what we're going to focus on today is the mass part of that, because we don't have a way of measuring that in living humans. And so most of our mass data around the beta cell comes from donors. And I'm going to admit that I'm totally ignoring insulin resistance, circadian rhythm, liver, all of those sort of things for part of my talk. We've heard some great discussions of those things earlier today. And we know there's going to be heterogeneity in all parts of this, and you'll hear that kind of weave through that. So the focus that we've had is what are the molecular alterations in the human islet that are responsible for the impaired insulin secretion in human diabetes. Now, if one thinks about the ways that one can study the human pancreas, there are different ways that one can do that. You can isolate the islets, just like Bala said. You can take sections of the pancreas. You can have cell lines and stem cells. And so really what we're going to talk about today are isolated islets and stem cells, not stem cells, but sections of the human pancreas. And we've transplanted some of those into immunodeficient mice. So the paradigm that we've been working on for about the last 15 years goes like this, that the organ procurement organizations in the United States are the ones that match the organ donors with the recipients. And when the pancreas is not transplanted, it comes available for research. And so two entities here, not-for-profits, match those with researchers. And so I've been part of a team at Vanderbilt, the University of Pittsburgh, and the University of Pennsylvania, where those donors who have type 1, type 2 are normal. The pancreas comes to our team at Pittsburgh or Pennsylvania or Penn, and they get tissue and islets from the same donor. Often that's not the case. You either have the tissue or you have the islets, and we think it's really important that one has both of those. And then those tissues and islets are distributed to collaborators in Vanderbilt. So it's schematically shown like this. Here's the pancreas. What happens is we take sections from the head, body, and tail, and those are processed in a number of ways so that you can study the tissue with spatial transcriptomics, with multiplex immunofluorescence, all sorts of things. And then for the remainder part of the pancreas, the isolated islets are studied. If you think about it, there's some things that you're going to learn from islets, like function, that you can't learn from sections. And there's some things you're going to learn from sections, like whether or not there's amyloid present, that you can't learn from islets. And then finally, we try to integrate this information into the clinical redacted summary that we have for the organ donor. Now, I'm going to show you a series of pancreas studies, but I just want to call out how the organ donors are so critical in this. Some of the donors I'm going to show you are 1 year old or 2 years old, so each pancreas that I show you represents a human tragedy, right? Somebody died and they graciously have donated their pancreas, and so you're going to see those things. And so I think having organs available for research is so important in moving the pancreas research forward. I'm going to tell you 3 vignettes about beta cell mass, about type 1 and type 2 diabetes. So what we're doing in this program, that's called the Human Pancreas Analysis Program, that's part of the Human Islet Research Network that's funded by the NIH, is we have the pancreas and the islets are removed that I talked about. And what we're trying to do is to co-register multiple experimental modalities. Whether we measure islet physiology, we measure the immunology of type 1 diabetes, we molecularly profile those, or we define the cell relationships to that. So we try to stack those up, integrate those, co-register, and we're making those available to anyone in the world as soon as we generate that data through 2 databases, one, the Pancreas Analysis Program called PancDB, and one called Pancreatitis. Now, let's talk a little bit about type 1 diabetes. I'm going to tell you about Sarah here. So she was 7 years old, developed type 1 diabetes. Blood glucose was 300. Turned out that her parents diagnosed it because she had an older brother who had type 1 diabetes. Never hospitalized for DKA, and she's been on insulin pump. So, that's sort of the prototype of what we think type 1 diabetes is. And so this is the schematic that we know so well, originally devised by Dr. George Eisenbarth in the late 1980s. And it sort of goes like this, the dogma does. One has a normal beta cell mass, something happens, it triggers an autoimmune process, and the number of beta cells begin to decline. And when one has lost a number of beta cells, maybe 75%, one transitions from dysglycemia into hyperglycemia. And now it's been categorized as stage 1 and stage 2, where hyperglycemia is not present in these stages here, but it's thought to begin here. So there are a lot of assumptions that we make about this, but I will show you a couple where we've not been correct, or we need more information. And so I'm going to show you some studies that we did at this stage of diabetes and recent onset individuals. So when we isolated islets from individuals who had recent, less than 5 years, onset of type 1 diabetes, shown in the red lines here, and we compared them to control islets and looked at their insulin secretion in response to high glucose or a cyclic AMP or low glucose. When one compares the type 1 and the type 2, they look pretty similar. You said, well, how can that be? Because they have type 1 diabetes. Well, the reason is because of the way I've graphed this, where I've graphed it on the y-axis per beta cell. So when one normalizes per beta cell, the beta cells that are remaining in individuals who have type 1 diabetes are normal, with the exception of maybe this little bump right here where they might have normal first phase insulin secretion. Of course, their insulin content is much greater, is much lower. So that was a surprise that the beta cells that are remaining there appear to be normal. In contrast, when one looked at the alpha cells, so these are the same islets where we've assessed glucagon, one can see the type 1 islets have less glucagon, they're secreted. It correlates with the fact that we know that individuals with type 1 diabetes have reduced glucagon secretion and have a propensity to hypoglycemia. So this tells you that reduced glucagon secretion, at least partly, is due to an intrinsic defect in the alpha cell, because these islets have been removed from the donor and they're studied in this perifusion system 48 to 72 hours later. So that means that whatever reason they had impaired glucagon in the individual, they still have impaired glucagon when they're isolated. And when we studied the pancreas numbers of these individuals, here's what we would see. A normal islet stained here, a 10-year-old and a 20-year-old. And when we looked at, say, in this recent onset type 1, 12 years old, and had 3 years of type 1 diabetes, there are some islets that look like this, where they look like they're normal islets. Most of them look like this, where there are very few green positive insulin cells. But there are normal islets in many of these individuals in the first 5 years of life. Now, if you study individuals from long-standing type 1 diabetes more than a decade, you'll rarely ever see any insulin positive cells. Now, in studies I won't show you, we've characterized these cells quite a bit, especially looking at the disordered glucagon secretion. And as I mentioned, the type 1 beta cells have normal insulin secretion, normal gene expression, but they have impaired glucagon secretion. We don't really know why that is. Here's a schematic that shows, say, in normals, you have alpha and beta cells juxtaposed, and you have normal alpha cell gene expression, normal glucagon expression. In type 1 diabetes, we know you have extreme beta cell loss, you're having hyperglycemia, intermittent hypoglycemia. So we think one of those mechanisms, most likely the first one, where there's not apposition of beta cells next to alpha cells, that these alpha cells then have altered gene expression, and that leads to impaired glucagon secretion. So we're testing that right now by exposing islets to these different conditions to see if we can recreate this disordered glucagon secretion. Now, here's one of my patients who always wanted me to go fishing with him, and he would bring me these fish. And so those are catfish, in case anybody's wondering. So he developed diabetes at the age of 27. 400, okay, you can see he's 79 years old, if he's 27 when he did that. This is in the 1960s when he had this. He was initially treated with sulfonylurea, caloric restriction, because everybody thought he had type 2 diabetes because he was 27 years old. He was then subsequently treated with insulin and lived with type 1 diabetes more than 50 years. And did very well overall. So the question is, what kind of diabetes does he have compared to the young girl? Now, when you look at studies that have come out of Richard Oram and others in the UK Biobank, it now appears that the age of 30, that up to 40% of the people who have type 1 diabetes develop it over the age of 30. So our paradigm, our way of thinking about type 1 diabetes needs to shift. But I do think we don't know whether she and he have the same disease. And these emerging concepts of diabetes, type 1 diabetes compared to any age, autoimmunity young does appear to have certain different features when one studies those. And whether you call it autoimmune diabetes of adults is the term that I prefer. Now, one of the other things going back to our paradigm is how many, we say you have a normal number of beta cells and then something happens and you begin to lose beta cells. Well, it turns out normal is hard to define. So here's work from Peter Butler when he was at the Mayo Clinic. And what Dr. Butler and his wife, Dr. Butler, did is they did autopsy studies on the pancreas of individuals who were not diabetic, and they measured their beta cell mass. And so you can see over an age range here, these are all non-diabetic, there's a huge variation in beta cell mass. There's some individuals who have very low beta cell mass, and there's some people that have 4 to 5-fold more beta cells. So if one thinks about how that might affect our risk of type 1 diabetes, if this was sort of the average of beta cell mass, and if you happen to be someone who had low beta cell mass or high beta cell mass, your time to getting diabetes is going to be very different. This is shown for type 1 diabetes, but you can see how the same paradigm would be in effect for type 2 diabetes. So the question is, how and when is beta cell mass determined? We're also interested in this time period of early life because when one looks at autoantibodies as part of the TEDdy study, this is Annette Ziegler's work, that in people who develop type 1 diabetes in 15 years, most of them develop autoantibodies in the first few years of life. So we become very interested in the early pancreas, and my colleagues shown here have studied over 90 donors less than the age of 10 using the paradigm that I showed you here. And I'll just show you some of that. So here's what it looks like in neonatal pancreas, infancy, 2 to 11 years of age. You can see how the islet cells begin to coalesce. One thing that was very interesting is the appearance of the islets changes. So this is what a normal adult islet looks like. This is what a normal adult mouse islet looks like. So early on, human islets look very much like mouse beta cells, islets in terms of their cell composition. So when we measured their beta cell mass over this age range here, we found that there was a range, but there was already huge variability in beta cell mass in the first few years of life. So we would have the paradigm that your beta cell mass is determined probably in the first decade of life, and that in utero events in the first 2 or 3 years either lead you to have, say, an average beta cell mass, a lower beta cell mass, or a higher beta cell. And then finally, I want to just say a word about type 2 diabetes. We know that it's a progressive disorder where one has insulin resistance, there's compensation for that, but when one fails to compensate, your beta cell mass goes down. And you can read these processes that people have thought, you know, is there islet amyloid, are there cytokines, is there beta cell differentiation? And so we wanted to investigate this. So what we did is we wanted to test some of these hypotheses. And the way that we did that is we gathered a series of donors, in this case 20, age 52. Average duration of type 2 diabetes short, because many of the studies with type 2 diabetes have put 5 years of diabetes, 15 years of diabetes, and we wanted to focus on the early stages of that. You can see they were treated with lifestyle and medications, A1C, that. So when we isolated their islets, we saw something very different from the type 1 islets. Here are the type 2 donors, and here is their control. So that tells you take those islets out of an individual who has type 2 diabetes, they still have an impaired beta cell function. In contrast to type 1, their glucagon secretion is normal. Remember, many individuals have hyperglucagonemia in type 2 diabetes, but here that's not an intrinsic action of the alpha cell, whereas the beta cell mass, the beta cell dysfunction appears to be. And to test that further, we transplanted some of these islets into immunodeficient mice, and when we studied them 2 months later, these islets still were impaired 2 months later after being in a normal glycemic, non-hyperlipidemic environment. So in studies I won't show you, we said that the intrinsic beta cell regulation is a key feature of this reduced insulin secretion, and they're present after removal. We found that their beta cell mass was normal in the early stages of type 2 diabetes, and we didn't find changes in islet neighborhoods in terms of vascular or neuronal tissue, and we didn't find any evidence of dedifferentiation while others have looked. So in work that we did with Steve Parker at the University of Michigan, we applied some computational approaches to try to correlate GWAS studies with what we found in cells. And here's Marcella and Steve Parker, and here are the other members of our team. And what we found is that when you looked at individuals who had type 1 diabetes, we found a reduction in an islet-enriched transcription factor called RFX6. But it turns out that it wasn't RFX6 that had mutations. What we found is that there were a network of genes that controlled RFX6 expression, and they're the ones that associated with the GWAS signals that were present in type 2 diabetes. So we think that this multimodal profiling of early stage type 2 diabetes shows that intrinsic beta cell regulation is a key feature driving reduced insulin secretion, and it's present after removal from the type 2 environment. Why are they dysfunctional? Well, we know that we didn't find evidence of dedifferentiation or cell death. We did find that this RFX6 transcription factor appeared to act as a hub gene that was associated with reduced insulin secretion, and we were able to confirm that by knocking it down. And so going about this approach using this was allowed us to use some of the GWAS variants to connect to isolated islets. So I presented you a very beta cell-centric view of diabetes, and let me summarize that to say that there's plasticity early in life. The determinants of beta cell ask how to maximize. Talked about type 1 diabetes is heterogeneous in its age of onset to genetics. The alpha cells are dysfunction, the beta cells are present and functional, and so how might we protect or amplify those? And finally, in type 2 diabetes, the beta cells are dysfunctional, and we didn't find evidence of things like glucose or lipotoxicity. And how you connect GWAS studies to genomics, to these molecular mechanisms, we talked about a way that one might do that. So, but really what we need to move is from a beta cell-centric view of diabetes to a more holistic view of diabetes and its complications. Now, we know all of these other processes, many of which have been talked about today, are critically important. So we have to integrate all of those together to get a true picture of type 1 or type 2 diabetes. And then finally, we know that the social determinants of health are a very important role in diabetes. So for example, early life events may influence beta cell mass, which might influence your risk. And so I think what we have to do is we have to acknowledge this heterogeneity, we have to incorporate it, and then we have to understand diabetes and classify it based on its pathogenic processes. Now, to make this, connect this to where we are today in Vellore, we know that insulin secretion, insulin deficiency, is a feature of type 2 diabetes in the South Asian population. What we don't know is whether that's fewer beta cells. We don't know if there's an impact on early life under nutrition, and we have no idea whether those beta cells are dysfunctional. And that's because we don't have studies like this in South Asian population. So this is a huge limitation. So while clinical studies to define insulin secretion are important, we also need to have studies where we're going to learn about these. And so I want to tell you about the final slide about one group that I'm associated with, because really trying to address the need, we need a pancreas biorepository in the South Asian population that would allow us to do some kind of molecular analysis that I talked to you about. So I'm fortunate to be part of a group that's headed by Dr. Sudipta in Hyderabad with other co-investigators at the University of Hyderabad or St. John's and Venkat Narayan at there. And we are in the process of establishing a pancreas biorepository to do some of the types of studies that I told you about in the South Asian population. So stay tuned, and hopefully we'll have some islets and some molecular profiling that will give us insight into what the pancreas looks like in individuals of South Asian descent. So I'll stop there, and again thank the organizers for inviting me to this very exciting conference. Thank you very much.